So it looks like we already have some attendees in the audience. My name is Megan Collins. I'm the research coordinator for CureGRIN, and I am joined today by some wonderful researchers who are going to talk to us about lots of different medications and how things work, and some potential treatments to consider for GRIN patients. So first off, we're going to have a presentation by Catherine Ensign, who is a PhD candidate at the University of Toronto.
Perfect. So hi, everyone. If you don't know me, I'm Kath. I'm doing my PhD in pharmacology. And today I'm just going to talk a little bit about the different treatment drug avenues for the different GRIN genes. And really, this is more of a talk for the parents to address some things that you might be wondering, but that are impossible to Google. So one of the things you might be wondering is, why on earth the kids are all so different from each other? So you probably already know that the GRIN genes make proteins that come together as a foursome of subunits. We call this a tetramer, which is either a mixture of GRIN1 and GRIN2, or GRIN1 and GRIN2 and GRIN3, or GRIN1 and GRIN3 proteins. And this complete complex forms what we call an NMDA receptor. And don't be frightened by this scary looking graphic. It's just to illustrate that, you know, when it's all put together, the point of the NMDA receptor is to regulate the flow of certain ions in and out of the cell, and your body's need ions in order to transmit signals throughout the body and keep everything working. But that still doesn't really answer the question of why kids with different variants to different genes need different solutions. Well, it turns out that depending on which proteins made by the different genes are in each NMDA receptor, the NMDA receptor will behave a little differently. So I'll just provide a couple of examples. For example, the GRIN3A subunit has a lot of control over how well calcium ions go in and out of the cell. GRIN2A has this special binding site for a very important messenger protein. And GRIN1 always has to be there because it contains the glycine binding site, and glycine has to be bound to the NMDA receptor each time it opens. So each of these are going to influence the properties of the receptor, and your body needs them in these diverse subunit assemblies for different things. And I just want to return to this graphic because it tells us a little bit about where the different ligands and drugs actually bind to the NMDA receptor complex in order to influence its activity. So we can see that the GRIN1 subunit is where the necessary glycine binding site is, which is also the D-serine site. Protyl is a tricky one as it sits actually between GRIN1 and GRIN2B when it's present, and so it would probably be a little higher up here. And then memantine sits down here in the pore loop, and magnesium, which normally keeps the channel closed at rest, sits about right about here in the middle of things. So here are just a few of possibly hundreds of examples of potential NMDA receptor targeting therapeutic treatments for GRIN disorders. So one of the more famous ones, of course, is D-serine. And this is an agonist of the GRIN1 subunit, meaning that it increases activity of the NMDA receptor. And rationally, this would be, you know, something that clinicians might consider for a loss of function mutation. And then there are memantine and ketamine, which are antagonists, which means that they decrease the activity of the receptor. And this is something clinicians might consider for a gain of function mutation. And then there are drugs like mebostino, and this is a positive allosteric modulator of GRIN1, which means that it binds to a special site called the allosteric site of the NMDA receptor, and it actually just increases the probability that an agonist, either, you know, something that naturally occurs in the body or a different drug, will bind to the receptor complex. And then there are negative allosteric modulators, such as this QNZ46, which is an experimental drug that has selectivity for GRIN2D containing receptors, which bind to the allosteric site and decreases the probability that an agonist will bind to the receptor complex. Then there are, of course, you know, vitamins such as magnesium, certain and specific polyamines such as spermine, which target the polyamine site of the NMDA receptor. Then there are certain and specific neurosteroids which target the neurosteroid site. And then, of course, there are these drugs that indirectly target the NMDA receptor. So again, we don't need to go through this graphic, but what it's meant to show is just how connected the NMDA receptor is to all of these other different processes in the body. And so either upstream or downstream of the NMDA receptor, this might represent an avenue for different therapeutic potentials in treating your child. So the key takeaways from this talk are that, the NMDA receptor is heavily studied, and this should be, a bit of a saving grace in terms of GRIN disorders in general, because it has many different identified ligands, and there are lots and lots of different things to try. Also that even though all the kids have different mutations to different NMDA receptor genes, they will all manifest in very different ways, and there are reasons for this. Lastly, I just wanted to say that, the most meaningful notes that you can compare as a parent, conversations with other parent, occurs between, yourselves and the parents of kids with the exact same or very similar mutations. And the idea there is just that, because all of the mutations are so very different, the ones that are most likely to be similar to your child will have, the exact same variant. So thank you very much.
Wonderful. Thank you so much for that, Catherine. So next we have a presentation from Dr. Zhang. And also it looks like we'll be joined by Paul as well when he gets a chance to log on. But Dr. Zhang, you can go ahead and share your screen and start presenting.
Okay. Thank you for having me here. And today I will talk about one patient with GRIN1 variants with treatment with memantine and some molecular mechanism. And most of the work was done by Dr. Yuan and Dr. Traner's lab. And this is the patient information. This patient now is 30 months old. He was born at term without family history of epilepsy. Parent first noted the patient has a startle movement during the first 1 to 2 weeks of life, during which patient extended his arm suddenly, and then each episode lasts only for 1 to 2 seconds. The typical epileptic spasm started at 2 months of age and developed tonic-clonic seizure after 10 months of age. The episode increased in severity and frequency and become too numerous to account. At the 4 months of age, EEG shows electrodecament with typical infantile spasm. ACTH was started to treat at 4 months of age. The epileptic spasm was less severe and demonstrated a 50% reduction in frequency without complete resolutions. After ACTH discontinuation, patient spasm recur up to 100 to 200 times a week. Patient also was treated with fobamate, clobazam, and vigabatrin, continue having frequent, numerous spasm and tonic-clonic seizures. Patient had severe developmental delay on 3 AEDs. On examination, patient was very drowsy, difficult to arouse, no eye contact, no tracking, with hypotonia, poor height control, and appendicular hypertonia and spasticity, diffuse hyperreflexia. MRI of brain at 3 months age was reportedly normal. This is the variants we found in the M641. We know the M3 is the transmembrane the M variant is in the transmembrane domain M3. This position is highly conserved across most vertebrate species. There are other 2 patients we found had the same mutation. One patient in Japan with similar onset at 2 months of age with kind of a breath holding attack, abnormal eye movement, and tonic posturing. And the EEG showed diffusely spike and polyspike wave at 3 months of age, which is similar to hyperthermia pattern. Patient also had severe developmental delay, other stereotyped movement. MRI of brain shows cerebral atrophy. Patient was refractory to multiple AED, including Depakote, clobazam, and phenobarbital. Another patient was seen in Phoenix, 3 years old, born unterm, and had a severe developmental delay, was noted at 4 months of age. Infantile spasm started at 6 months of age with hyperrhythmia pattern. Spasm temporarily resolved with ACTH treatment. Unfortunately, the spasm recurred and the refractory multiple anti-seizure medication and VNS placement. The MR also shows some cerebral volume loss and the syncope. This is some functional study about the variants M641. The number one, we see the voltage, the M641 variants reduced voltage-dependent magnesium inhibition by 8-fold. We also found M61 variants enhanced NMDA receptor, synaptic and non-synaptic signal by 3 and 2-fold. The M641 variants is also very sensitive. It's more sensitive to FDA-approved NMDA receptor channel blockers, including memantine, ketamine, dextromethorphan, dextrorphan, and amantadine. This is how we treat with memantine above this patient. The memantine starts at 14 months of age with 0.2 milligram per kilogram per day divided by 2, and slowly increase to 0.4 milligram per kilogram per day. And at the same time, we continue his seizure medications. 3 weeks after memantine treatment, his spasm and tonic seizure reduced significantly from 150 to 200 times a week to 1 to 2 times a week. Interestingly, patient was accidentally missed 2 days of memantine after 3 months of treatment. Then his seizure increasing significantly, up to 30 to 50 times a week of spasm and 15 to 20 times a week on tonic-clonic seizures. 1 week after we start the memantine, his seizure reduced significantly to 10 to 20 times spasm a week and 5 to 10 times tonic-clonic seizure a week. 6 months after the treatment, after the restart treatment, patient's spasm remain under good control. Repeat EEG at 3 months of age after treatment demonstrate mild slow of the background, no epileptiform discharge. You can see on the upper level, this is the one before the treatment, and the bottom one is the after treatment. Patient was more alert and calmer by parent report. Patient was last follow-up. After 9 months treatment, patient seizure remain under good control. And at the same time, we also decreased his anti-seizure medication, fobamate, vigabatrin, and clobazam. Summary. Recurrent de novo GRIN1 M641 variants was identified in patients with early onset epileptic encephalopathy. The M3 variants cause conflicting functional changes. Number 1, significant decreased voltage-dependent magnesium block with mild change in agonist potency and proton sensitivity. 2, reduced channel open probability. 3rd, reduced receptor cell surface expression. M6041 variants contribute to enhanced NMDA receptor synaptic and non-synaptic signal. A set of NMDA antagonists was evaluated to mitigate the altered variance function to explore potential personalized treatment. The memantine trial significantly improved patient seizure burden, and in the future appropriate clinical trial, including more GRIN1 patients, are necessary to further establish the safety and efficacy for long-term treatment with memantine. Thank you.
So much, Dr. Zhang. So now we'll hand it over to Paul, who will describe his experience as a parent of a child who has been prescribed memantine.
Okay, you have both of us today. How are you? Good to see you. So basically, when they started the memantine, or Nmda as we know it, the only persons that we told that Austin was taking that new drug was anybody medically involved, his nurses, the school, his one-on-ones at school, because we tried so many things prior to that, including holistic approaches. You know, as a parent, we want the best for our kid, and we tried everything. So the only persons, like we said, we told were just anybody medically involved in his life. We didn't tell his grandparents, siblings, friends, neighbors, anybody that sees Austin on a daily basis. We didn't tell them that we started this new medicine. So we noticed pretty much immediately Austin's seizures in the daytime subsided, like in the awake state. And honestly, since, Wilda can confirm, but since we started this, he hasn't really had one seizure in the awake state. He still has some when he sleeps at nighttime, but other than that, it's been working wonders. We're very happy with it, and with Emory University, working with them, they were awesome. What else can we say? I mean, the one advice that I would give to parents is that if you do start a new medicine, just to keep it within the immediate family. Don't tell people who's, other than medically involved in the child's life, to see if it really is making a difference. Because all we could see is the outside and how the child behaves. And we don't know anything medically going on inside. So we'll leave that to the doctors to do all that testing. But it's nice to hear other people that haven't seen your child in a while to say, oh man, we see a change in Austin. Did you guys see something new, or did you do something new? So that would be our recommendation for anybody trying any new medicine with their child. Anything?
Wonderful. Thank you so much for sharing. We really appreciate that.
No problem.
So now we're going to hand it over to Dr. Muglia, who has some information to share with us about Radipradil.
Yes, thank you. Can you all hear me okay?
Yes.
And you can see the slides, I suppose. Very good. Okay, well, first of all, thank you, Megan, and to you and Keith and Denise for giving me and the team the opportunity to introduce you to our project. This is a project we were working on for a while, but now since a week we managed to start a company out of it. So I'm really, we're really early days. So here is just to give you a quick introduction. So the company, we name it GRIN Therapeutics because the primary focus is to develop a Radipradil, that is a candidate drug for children that have certain genetic variants that lead to gain of function. And so, of course, we have a little time here and we're really at the beginning. So the only thing we're going to do is to give you a quick introduction to the program. Surely we're not going to be able to address and answer your question, but I would like to reassure you that this is just the first time we talk to you about the project, and we would like really to start a dialogue and collaboration with the community to make sure that whatever we do in the program is the most appropriate thing to do for the children. And so I'm not so sure. Hillary was part also of the team and is our head of community engagement. Was trying to connect, but probably had some issue. I don't think she managed to connect back, so I'm going to continue myself. Unless Hillary is there. No, I don't think it is. Okay, so but basically, you see on the slide that there is a snapshot of the team that most of it is connected today. And, there are also other people behind, but these are the key players at the moment. As I said, it just started, and I'm going to start to give you a few more details about Radipradil. And I'm glad that, the previous talk explained a bit of the pharmacology, so they make my presentation hopefully a bit easier to follow. So Radipradil, first of all, it's a clinical stage. The molecule, the candidate drug, has been in development for quite some time. So there are more than 400 adult patients that they have been tested with the molecule. So we have extensive database in adults, safety database in adults with various dosage and various information. And out of all this information, we managed to come up with an understanding of what would be the appropriate dose for infant and for children. And we started, some time ago before we made the company, with the testing in infants with infantile spasms. So we have accumulated experience with 3 infants, and they were, of course, all with severe spasm. They hadn't responded to ACTH or vigabatrin, and so they have a test. We tested radiprudil for up to a month in these 3 infants, and one of them had seizure freedom, and the other had the reduction of seizures. Difficult to come up with any conclusion, but surely was safe and well tolerated in this infant, and so that gives us, a good hope that the drug will continue to do well in pediatric population. And now, because of the mechanism of action, you heard on the previous talk, and you saw that they are what we call negative allosteric modulator. And so radiprudil, as you might associate it to the other name, there was efemprudil, it binds to the same site. So it's a negative allosteric modulator, so modulate negatively the receptor. And for that reason, we believe it might be able to control seizure or the rest of other symptoms that the children suffer from when the children have a gain of function genetic variance. So the drug is a negative modulator, and the gain of function increase the responsiveness to glutamate. So for that reason, we believe it might be an opportunity for these kids. We have tested in a few mutations in vitro, and that showed that basically this overactive receptor coded by the genetic variants that give gain of function, it can be to some extent controlled. I would say almost normalized. I would say normalized in its activity by radiprudil. At the time, there were not that many models and that were suitable to do testing, particularly for seizure and GRIN models. So we had done a variety of animal models that have seizures, and we showed the effect of as an anticonvulsant or radiprudil in many of these models. And so we also collected information about the relevant dose, and so we have all this information now, together with the formulation of the drug that is suitable for a pediatric population. Is a syrup made in suspension. So we have all this information and all this data that allow us to do a clinical study, and this is that will test initially the safety and the tolerability and the different doses, what effect we can achieve with this drug, and then progress into the development. As you know, probably we have to do this stage. At different stage, we will increase the number of patients until a point where we will understand its activity, its efficacy. So the first step will be to do this clinical study, and that they will be preparing to do that study in the coming future. And now I'll just maybe to be more specific about the drug, because you heard about memantine. And I want to show you here, there's a lot of details in this slide, but 2 key points. Well, first of all, I should say that, as you know, every children has a different mutation almost, or at least there are many, many different kinds of mutations that give a different biological response. And the reason I'm saying this is that because memantine, we have shown in vitro that in some patients with a certain GRIN to B mutations, it might not be effective, at least it's not effective in vitro. And you see on the right side that memantine, you see these different lines, these curves. And one specific curve that corresponds to a genetic variance, it doesn't overlap with the others. That means that in this case, memantine is not normalizing the overactive receptor. On the left side, you see radiprudil, where all the lines are overlapping, meaning that in the same mutation, this time is normalized. So I think this is saying that, in some patients, we might get a better response to radiprudil than memantine, the concept and the idea here that we will be moving very cautiously, trying to understand as much as we can in vitro first, which patient might be suitable for benefiting from the drug. And so as such, we will be testing Radiprodil in well-characterized patients that may get benefit. And this is all about GRIN2B. Because of the biology and the pharmacology, there might be potential for gain of function in also other receptors like GRIN1 and GRIN2A. At this stage, we have no data ourselves. There are a bit more data in the literature and in different labs, but we will be testing the opportunity also for these other genetic variants in the other subunits. But at this stage, we don't have any data we can share. So I'll get to the next slide to conclude, and just to say that, as I said at the beginning, this is nothing we can do by our own. We would like really to see this as the first as part of our conversation, where we start to share some highlights of the program, and we would like to continue with this dialogue with the community and, of course, the scientists and the clinician. So we will continue to do that, and in the meantime, we will prepare all the documentation required to be able to get approval to start the study. And if everything goes fine, we might be in a position to do a clinical study next year, maybe at the middle of next year, around those timelines. So I'll just conclude here, and thanks for listening to me, and happy to, if we have the opportunity now or later on, to address any question you might have about our program.
Wonderful. Thank you so much, Dr. Muglia, as well as Dr. Zhang and Paul and Catherine, for all sharing some very exciting information today. It looks like so far we had one question in the Q&A that's already been addressed, and then we have a question in the chat that I believe is probably directed to Dr. Muglia, related to when you talk about a variety of animal models available, which ones do you have so far?
The audiogenic seizure model is the one that we use mostly. We use in a variety of setting, or at least with a different variety of baseline drugs. As you probably know, when we do trials, but also in clinical practice, we add the one anticonvulsant on top of the other. So what we did in the audiogenic model, we tested the efficacy on top of levetiracetam, carbamazepine, and diazepam, so that are some of the drugs that often are prescribed. We also did a study with the pilocarpine model that is a bit more of a subchronic treatment, and so that's kind of the main studies that we have done. The other study we have done is also a different age stage of the rodents, because we see a prevalent activity in the younger animals than in adult animals. And at the moment, we are designing a study. There's been a new animal model for GRIN2A gain of function mutation that also with the audiogenic seizure can be tested at the activity, and we are in the process of starting that testing. So that's so far all the data we have in preclinically.
So it looks like we have a question related to any trials for drugs and challenging behavior. So I guess we'll open that one up, Dr. Zhang or Dr. Muglia, if anybody has any thoughts about trials for drugs with challenging behavior.
I don't aware any new clinical trial for just specific for the behaviors. Patient has a intractable epilepsy, no matter what the etiology is, tends to have more behavior problem. This is very common, and the behavior problem is always challenging for us too. We always consider to cooperate with the psychiatry to treat. At the same time, we treat the seizures.
Great, thank you for that explanation, Dr. Zhang. So our next question is, do you have a database of patients that are interested in a clinical study? If not, how can we participate in studies? If not, how can we participate if the studies are open for the public?
Yeah, no, I think that's a very important question for us. So, we we are well connected to the scientific community, and with Johannes and team and Steve, at the various sites that developed the CureGRIN portal, and so we will be working together with them, with the foundations, to understand where we can best start. So, as I said, at the moment we don't have any information. We know that this information exists, and we will collaborate to make sure, as I said, that we will do the optimal job.
Perfect. So we had another question about what therapies are considered for GRIN 2A with an underactive NMDA receptor.
So I can probably take this question. For a loss of function like GRIN 2A variant, generally because a lot of the therapies target the GRIN 1 subunit, that's still probably your best druggable target, and that's something you can talk to your clinician about. There are some, positive allosteric modulators that are being developed that have specificity for the GRIN 2A. This is something that can be looked into much more easily on Google if you search for GLUN2A instead of GRIN 2A, because in the scientific community, the protein for GRIN 2A is referred to as GLUN2A. So that would be kind of my tip there. And as far as I know, all of those drugs are quite experimental, but just to say that, science is advancing.
Thank you for that explanation, Catherine. So we had another question about, could these drugs benefit older patients or non-epileptic patients?
Yeah, that's such a great question. I think so, most definitely. I don't think that age is necessarily a factor in treatment here. Of course, the longer that, somebody's seizures are uncontrolled, the more complicated things get at a brain-wide level. But of course, I think that these avenues have potential for older patients, non-epileptic patients as well. That's getting into a very nitty-gritty science question, but it's really hard to define what exactly constitutes epileptic activity, and I definitely think that given that there's so much commonalities among the variants at like a level, it may not necessarily matter whether they're epileptic or not. I don't know how much sense that makes, but that's my rationale.
So I see another question related to AMPA receptor medications. I just wanted to let that person know that we did have another person who was planning to present today but couldn't be here last minute. I'm not sure if any of the other panelists would like to answer if there are any AMPA receptor medications, particularly for loss of function, that anyone knows of.
Yeah, so I am an NMDA receptor researcher, so I'm definitely not an expert, but AMPA receptors are a lot like NMDA receptors, and they are, inherently quite druggable as well. Different drugs that exist for AMPA receptors as well. And so, I think that the therapeutic avenues for AMPA receptor related genes are just as bright as NMDA receptor related genes.
There's only one AMPA receptor antagonist on the market called Facampa. But that means for the gain of the function of the AMPA, probably not for the loss of function. I have a question for Dr. Muglia.
Sure.
What's the difference for the radiprotil and the fulvomate? The fulvomate has been on the market over 30 years. Do you see it's also working on the GRIN 2B?
Yes, it's a good question. I think it's yes. In fact, we see that fulvomate is effective in infantile spasms. I'm not so sure that there are direct experience on children with the GRIN variants. The difference, though, is that for the NR2B, fulvomate has also other activities on GABAergic system, for example. So it's a bit of a more diversified mechanism, I would say. So it's not as specific and potent as radiculate. And of course, this is in the efficacy and pharmacology part, but as you know, there is a safety and tolerability issue with the felbamates that restrict its use. But that's another story.
Thank you.
Wonderful. Thank you so much. So our next question, I believe, is there any experience on suitable drugs for GRIN1 with severe breathing disorders or apneas? Any thoughts?
I'm not a clinician, so I unfortunately don't have much insight into how to treat specific symptoms.
Yeah, it's difficult to answer because, well, first of all, there's not an answer or clear answer or anybody that knows. And, I would say that a lot of things that we are discussing in terms of treatment are, particularly when you target the primary cause of the disease, in theory, you should have an effect on other symptoms. So if you target the primary cause, potentially there is an effect on apnea or breathing. The fact that, ourselves, for example, we are focused on seizure as many others is because this is an epiphenomenon that can be more easily measured, and we can get an approval more rapidly. At least we can communicate data more clearly. But clinically or biologically speaking, we should see an effect on also other symptoms. So I won't expect that there will be a specific treatment just for breathing, but will be important to find a treatment that also is a causative and go the causation of the disease, and will help as such breathing. That's, I know that, it's not a perfect answer, but I'm also sure someone, the other clinician might also in the call might be able to address in the other session as well.
Perfect. Well, thank you all for your time and attention. I really wanted to take a chance to thank our speakers and to Dr. Muglia for sharing an exciting announcement with us, Dr. Zhang for sharing his work in recent publication, Catherine with her great overview that she gave us, as well as Paul sharing their family story. We really appreciate everyone taking the time to learn more about drugs and molecules and what treatments are out there for GRI patients. So it looks like we are just about out of time. So I wanted to thank everyone again, and we'll see you in another breakout session.
Thank you.
Everyone.